I'm Donovan Most. I'm an assistant professor of psychiatry and a research scientist with the VA Ann Arbor Center for Clinical Management Research. And today we're going to be talking about co-prescribing of opioids with other medications and what to look out for. So I think a good place to start is a black box warning from the U.S. Food and Drug Administration that came out in the fall of 2016. And that warning said, concomitant use of opioid pain or cough medicines and benzodiazepines, other central nervous system depressants, or alcohol may result in profound sedation, respiratory depression, coma, and or death. And so hopefully that really has gotten your attention. That's the highest warning that the FDA can give about prescribed medications. So what exactly are CNS depressants that you shouldn't use with opioids? So the most common group are the benzodiazepines, or benzos, I might call them. So those are things like alprazolam or Xanax, lorazepam or Ativan, clonazepam or Klonopin. Those are the three most commonly prescribed benzos. They're sort of the first cousins of benzos called the Z drugs, like Ambien, and those are commonly used for sleep. Less common are the muscle relaxants like baclofen or Flexeril, and then finally things like antipsychotics like Seroquel, Geodon, or Latuda. Those are commonly prescribed for major psychiatric illness like schizophrenia or bipolar disorder, but they also get used a lot off-label for anxiety or for sleep, and also sometimes in people with depression. And so the FDA warning again said you should be very careful about prescribing an opioid with any of these other CNS depressants. And just to add, then there's the CDC prescribing guidelines that specifically say you shouldn't co-prescribe opioids and benzos, so the FDA black box warning is more broad than what the CDC prescribing guidelines say. Okay, so why does this matter? Co-prescribing really is very common. So there's a paper that I published within the past year that says among those who are prescribed a benzo, nearly 20% are also prescribed an opioid. And then if you look at the flip side in this paper by Sun et al., among those who were prescribed an opioid, 17%, again, nearly 20% were prescribed a benzo. So co-prescribing of these medications really are very, very common, which is really quite concerning given how severe the potential health effects and consequences are of co-prescribing. So the concern, again, about co-prescribing is that you have this increased risk of overdose. And so two important analyses here. The first from Sun et al. In 2017 looked at opioid users both with and without a benzo prescription at the same time. Those who were prescribed a benzo had nearly double the risk of an emergency department or inpatient visit related to an opioid overdose. Then in the Park et al. Paper that was published a few years earlier, they were looking at the risk of overdose mortality in those patients who were prescribed an opioid, either with or without a benzo. And essentially, the risk of an overdose increased in a dose-response fashion with both the dose of the opioid, but also with the dose of the benzo. So if we look at the figure to the right, that's showing that current benzo users are that blue line, and you can see that it's the highest line at every dose of opioid. In another table in that paper, they also show that the risk of overdose also increases with the benzo dose. So essentially, if you're co-prescribed an opioid and a benzo, your risk of overdose mortality goes up both with higher doses of the opioid, but also with higher doses of the benzodiazepine. And again, given how commonly these two medications are co-prescribed, this really should be very concerning. And overall, there are a lot of overdoses that are simply associated with benzodiazepines. So this is a figure that comes from the Centers for Disease Control and Prevention that shows what's been happening to overdose deaths involving benzos from 2002 through 2016, and you can see that it's essentially just gone up, up, and up. So part of that story is increased risk related to opioid overdose. And so in that top bullet, you see that about 30% of all opioid overdose deaths involve benzodiazepines. On the flip side, about 3/4 of all benzodiazepine overdose deaths involve opioids. So again, this combination of medications is very concerning, and they each play a role in overdose deaths. So what to do? I think the most important thing is to really think about, does the patient need to be prescribed both of the medications? If, in fact, it's true and the patient really does benefit from co-prescription of both medications, then I think you need to be very careful about use of additional sedating substances. So it might be alcohol, it might be marijuana, it might be another medication on that CNS depressant list, like a muscle relaxant or like an antipsychotic. And then finally, I think if a patient decides that they want to stop a medication, either the opioid or the benzo, the most important thing is to pick one of them and to conduct the taper very carefully and very slowly. This is particularly true for benzodiazepines and Z drugs because we know that patients can experience very uncomfortable withdrawal symptoms. And in the case of benzo specifically, the patient can actually become delirious and can actually die from acute benzodiazepine withdrawal. So hopefully the patient is willing to taper their dose of either the opioid or the benzo, but it's really importantly to do it very slowly and gradually. You want the patient to feel mastery over their ability to live without the medication. And so part of how you do that is by a slow taper where they don't have severe withdrawal symptoms, and so they really feel in charge of the situation and don't feel like they need to increase their dose because of how uncomfortable they're feeling.